there are a lot of medicines which are given, and I will first enumerate all of them just to make you understand. So, drugs used in management of IBD. I am going to first enumerate them. Okay. So, they are 5 aminosalicylic agents, 5 ASA agents. Aminosalicylic agents. Then there are antibiotics. Which antibiotics? Generally we are giving ciprofloxacin and metronidazole. Here which 5 ASA agents? We are using sulfasalazine, ovalsalazine and balsalazide. Then there are glucocorticoids. Then azathioprine and 6 mercaptopurine. Then there is methotrexate, cyclosporin and tacrolimus. Okay, these were the conventional drugs which are being used in management of IBD, and there are various monoclonal antibodies also which are being used. I will write their names here. Their names are infliximab, adalimumab, certolizumab pegol, natalizumab, vedolizumab and golimumab. These are name of the monoclonal antibodies which are being used in management of IBD. Okay, now first of all I am going to discuss the 5 ASA agents. Okay, so I will first start with the 5 ASA agents. 5 ASA agents or the aminosalicylic acid agents. They are the mainstay of therapy, mainstay of treatment in both ulcerative colitis and Crohn's disease. A few things which I will ask you to remember, like in each of the drugs you have to first remember whether it is being used in ulcerative colitis or Crohn's disease or both, and whether it is being used in mild disease, moderate disease, or it is having a role in severe disease. Okay, this is what is more important to remember. Here 5 ASA agent is the mainstay of treatment in both ulcerative colitis and Crohn's disease. Now what is the mechanism of action? The mechanism of action, it is mainly anti-inflammatory. Okay, so there is inhibition of NF beta activation. There is inhibition of prostaglandin synthesis, and there is scavenging of free radicals. Mainly it is anti-inflammatory. Okay, now we are giving 5 ASA. Okay, there is a problem with 5 ASA that up to 80 to 90% of 5 ASA, it is getting absorbed in small intestine or the proximal small intestine, but majority of the ulcerative colitis and Crohn's disease, they are present in the distal small intestine or in the colon and rectum. Okay, in the colon and rectum. Okay, so if we are giving 5 ASA alone, then our drug is not reaching to the required place. So that is why we are combining it with a carrier which helps in delivering the 5 ASA moiety in the distal small intestine or the large intestine. Okay, So 5-ASA alone is getting absorbed in small intestine and does not reach the distal small intestine and large intestine. So it is joined with carriers okay. Now I have told you the name of three drugs. First is sulfasalazine. Okay. Second is olsalazine. And third is balsalazide. Okay. Now you have to remember this sulfasalazine is 5-ASA plus sulfapyridine. Okay, this olsalazine is 5-ASA plus 5-ASA and this balsalazide is 5-ASA plus 4-ABBA. Okay, this ABBA is amino benzoyl beta alanine. Okay, this it is amino benzoyl beta alanine. Okay, so here in sulfasalazine the carrier is sulfapyridine. Olsalazine is combination of two 5-ASAs and in balsalazide the carrier is 4-ABBA, that is amino benzoyl beta alanine. Okay, so here the bond is azo bond. So they are linked by azo bond. This 5-ASA is helpful in the anti-inflammatory. It is anti-inflammatory. And the sulfapyridine is helping as a carrier. And it is responsible for majority of the side effects. But it helps in delivering the 5-ASA to the large intestine and to the distal small intestine. Okay, so this is all about 5-ASA agents. Now we are going to discuss the antibiotics. Antibiotics, I have told you, it is ciprofloxacin and metronidazole. Okay, we are using ciprofloxacin and metronidazole as antibiotics. They don't have a role in ulcerative colitis and they have a role in Crohn's disease, in perianal Crohn's disease, in fistulizing Crohn's disease. In cases of ulcerative colitis, after total proctocolectomy, we are doing pouch formation, and in case if there is pouchitis, then there is the role of these antibiotics. Otherwise, as such, in ulcerative colitis, medical management, antibiotics are not having any role, and they are having mainly the role in Crohn's disease. Okay, so these antibiotics, they are used in active inflammatory Crohn's disease, fistulous Crohn's disease, and perianal Crohn's disease. So they are being used in Crohn's disease. So there is no role in treatment of active or stable ulcerative colitis. Okay, whereas there is role of these antibiotics role in pouchitis. Okay, and this pouchitis occurs in ulcerative colitis after total proctocolectomy with ileal pouch, anal anastomosis. If there is development of pouchitis in that pouch, then there is a role of these antibiotics. Okay. Otherwise, in general, they are having a role in Crohn's disease. Okay. So now the next topic is glucocorticoids or steroids. We all know that it is inflammatory bowel disease, and glucocorticoids are helping in decreasing the inflammation. Okay. Here glucocorticoids help in, or they are used in inducing remission in Crohn's disease and ulcerative colitis, both. Okay. Now, this you have to understand in IBD, because there is a chronic relapsing course. Okay. The disease activity increases, it goes down. So what we want is, we first want to induce remission. Disease activity is high, we want to induce the remission and decrease the activity of the disease, and next thing we want to maintain this remission here only, so that again the inflammatory activity should not go up. Okay. So initially we want to induce remission, then we want to maintain this remission here only. Okay. So these glucocorticoids are helping in inducing remission. We cannot give a person a glucocorticoid for the lifetime in these cases. So the main role of glucocorticoids is in inducing remission, and it is helpful in both ulcerative colitis and Crohn's disease. Okay. Now, they are having no role in maintenance therapy. This is important. Okay. They are having no role in maintenance therapy. So we are using oral glucocorticoids also, IV glucocorticoids also. Oral is generally given in mild disease or in some moderate disease. In moderate to severe disease, we are preferring IV steroids. Oral, we are using Visolone, that is having prednisolone or prednisone. Oral, we are using oral prednisone, and IV, we are giving hydrocortisone and methylprednisolone. Okay. Now there is a special steroid, that is budesonide. There is a special characteristic of budesonide, that whole of the budesonide is released entirely in the colon. Okay. So overall the side effects are very less with budesonide. Okay. So budesonide is released entirely in colon. So there are minimal steroid related side effects. So here the steroids are being used in inducing remission. Okay. This is important. Okay. Now, next drug is azathioprine and 6-mercaptopurine. Azathioprine and 6-mercaptopurine. So, if a patient is having steroid dependent inflammatory bowel disease, and whenever we are decreasing the dose of the steroid and whenever we are stopping the steroid, the disease again flares up. In these cases, there is role of azathioprine and 6-mercaptopurine. Okay. So they are used for management of steroid dependent IBD. They are used in both UC and Crohn's disease, steroid dependent IBD. They are also having a role in used as maintenance therapy in both of them, both ulcerative colitis and Crohn's disease, and they are used for treating active perianal disease and fistula. here you can see that they are having a role in both, in almost everything, in management of steroid dependent IBD, in maintenance therapy, and in treating active perineal disease and fistulas. Okay, but their role in inducing remission is not there. Okay, so this you have to remember. They are being used in almost everything, but their role in inducing remission is not there. We have to first induce remission with the steroids, then we can start this azathioprine or 6-mercaptopurine. Okay, and then we can use them as maintenance therapy. Now, the next drug is methotrexate. Methotrexate is used in inducing remission and reducing the steroid dose. Okay, then it is effective in maintaining remission, in active Crohn's disease, and it is having a good role or a promising role in the maintenance therapy also. Generally, we try to maintain with the 5-ASA agents. If it is not being maintained with the 5-ASA agents, you go for azathioprine 6-mercaptopurine. If it is not being maintained with azathioprine 6-mercaptopurine, then we have a space for methotrexate also in maintenance of the remission. Okay, so it is almost used in everything. It can induce remission, it can decrease the steroid dose, it can help in maintenance of the disease also. Okay, that is methotrexate. Now the next drug is cyclosporine and tacrolimus. Cyclosporine and tacrolimus. This cyclosporine is used in severe ulcerative colitis. So the majority of the cases, the drugs which are being used, I have already discussed. Now this cyclosporine is having a role in severe ulcerative colitis only. Okay, and if this ulcerative colitis is refractory to IV glucocorticoids or IV steroids, then only we can use cyclosporine. If there is very severe ulcerative colitis, weight toxic megacolon, not responding to IV steroids, then we have a space for cyclosporine here. Okay, and in tacrolimus, it is good role in children with IBD. Okay, good role in adults with extensive small intestine involvement. Okay, or adults with steroid dependent or refractory ulcerative colitis and Crohn's disease. So it is having a role in both. Majority of cases it is used in Crohn's disease. It is also used in refractory fistulizing Crohn's disease. You can see here that cyclosporine is mainly used for severe ulcerative colitis and tacrolimus is mainly used for severe or refractory Crohn's disease here. It is also having a role in steroid dependent or refractory ulcerative colitis. Okay, now the next we are going to discuss the anti-TNF therapies. Okay, anti-TNF therapies. I have already enumerated the names. I will again enumerate the names. The anti-TNF therapy is infliximab, adalimumab, certolizumab pegol, and golimumab. these four are the anti-TNF therapies. So the question is going to ask like certolizumab pegol is anti-TNF therapy. Okay. Now, first is infliximab, adalimumab, certolizumab pegol, golimumab. So infliximab is a chimeric IgG1 antibody against TNF alpha. It is anti-TNF therapy against TNF alpha and it is chimeric antibody. Okay. Already we know that it is a monoclonal antibody against TNF alpha. Then this adalimumab is a humanized recombinant IgG1 monoclonal antibody against TNF alpha. Okay. This is against TNF alpha. This we know now. This certolizumab pegol is recombinant Fab antibody, or we can say antibody fragment against TNF alpha, and this golimumab is fully human IgG1 antibody against TNF alpha. So this is a question which is being repeatedly asked: which among the following is a humanized one, or which among the following is a fully human, which is chimeric, which is the fragment. All these questions I have given here. This is a recombinant antibody fragment. Certolizumab pegol, golimumab is a fully human, and adalimumab is humanized. Okay. Now the next question is, which is being used in ulcerative colitis, which is being used in Crohn's disease. Okay. So now the infliximab is, we are using mainly infliximab in Crohn's disease, especially if a fistula is in Crohn's and is not resolving. Okay. And this is a basic common sense. If the disease is very severe and it is not being settled with the routinely available medicines, then only we are using these monoclonal antibodies, because the cost is very high. So this is obvious that they are being used in moderate or severe disease which is not responding to the conventional medications. Okay. Now this infliximab is used in active Crohn's disease, which is refractory to steroids, 6-mercaptopurine, azathioprine, or 5-ASA agents. Okay, this is obvious. So this is used in active Crohn's disease or Crohn's disease with perianal or enterocutaneous fistula, which is refractory. Okay, and moderate to severe ulcerative colitis, which is not responding. Okay, this is obvious. This is regarding infliximab. Okay, now I am going to discuss about adalimumab. Adalimumab is used in moderate to severe Crohn's disease, or moderate to severe ulcerative colitis. Okay, this is also obvious. Now you can see here that this infliximab and adalimumab, they are used in both Crohn's disease and ulcerative colitis. But this certolizumab pegol and golimumab, they are mainly helpful in one disease only. So this is just to make you understand. This certolizumab pegol is having a role in induction of clinical response in active inflammatory Crohn's disease. Okay, so basically if there is active inflammation in Crohn's disease which is not responding, then we can use certolizumab pegol, and this golimumab is mainly used in moderate to severe ulcerative colitis. Okay, so certolizumab pegol is only for Crohn's disease. You can remember it with this C in certolizumab pegol and being used in Crohn's disease, and this golimumab is used in ulcerative colitis only. And infliximab and adalimumab, they are used in both ulcerative colitis and Crohn's disease. Now the next treatment is anti-integrin therapy. Anti-integrin therapy. Now there are two drugs in anti-integrin therapy. First is natalizumab. Second is vedolizumab. Okay, this is against alpha 4 integrin. This is anti-integrin. Okay, so this natalizumab is against alpha 4 integrin, and this vedolizumab is against alpha 4 beta 7 integrin. Okay, MCQs has been asked on them. Now this natalizumab, as the name suggests, ZU, it is recombinant humanized, okay, IgG4 or immunoglobulin antibody against alpha 4 integrin. Okay, now what is the role of natalizumab? It is used in induction and maintenance of therapy in Crohn's disease. Okay, so mainly they are used in Crohn's disease only, and used in treatment of Crohn's disease which is refractory to treatment of anti-TNF therapies. Crohn's disease refractory to anti-TNF therapy. A few patients are not tolerant to the anti-TNF therapy also. If it is refractory or intolerant to the anti-TNF therapy, then in those cases we can use this natalizumab. Intolerant to the anti-TNF therapy. Okay, whereas this vedolizumab is used if there is inadequate response to steroids or anti-TNF therapy. Then we can use this vedolizumab. Okay, so now